Hello everyone. Today we have with us Dr. Makaran Kochikar. Dr. Makaran Kochikar is chairman of the Department of Uro-Oncology at Siddhivinayak Ganpati Cancer Hospital, Meerut. Dr. Makaran Kochikar has rich experience of 18 years in the field of urology and oncology and carries out the treatments with utmost precision and efficiency, ensuring the patient's health is in safe hands. We are very happy to have him with us here today. Over to you, sir.
Good morning, Dr. Gulshan, for having me over for interaction on a bladder cancer. Bladder cancer is a very common problem in urological oncology. If you ask me, the entire urinary tract, the bladder cancer tops the list. Then comes the prostate cancer, then comes the kidney cancer, and then subsequently rest of the organs come along. So I'm pleased that Ipca and your team have decided to have an interaction on a bladder cancer.
Could you tell me how serious is this tumor of the bladder?
Yeah, just let me take you through what bladder cancer means, because we have a sort of audience which will have sort of a mixed kind of experience. You mentioned about Siddhivinayak Ganpati Cancer Hospital, the foundation hospital where we started urological oncology work. And it was 1998 we established a uro-oncology services in this hospital. First time of this in this part of the world, very exclusive uro-oncological work. Recently, we have launched a new hospital which is called as Ushakal Abhinav Institute of Medical Sciences, a multi-specialty hospital. We will be heading the urology and urological oncology and providing services there as well. So talking of bladder cancer, we all know the urinary tract is made of 4 organs. One is kidney. Kidney forms the urine. Then the urine comes along through the urethra into the bladder. This is the male prostate here. That's the genitalia through which the urine actually comes out, and these are the testes. And what we're talking about is a cancer in a bag of urine, which stores sort of a urine here, and cancer in the bladder, what we are going to talk about today. Now, it is a common problem, as I said to you. To answer your question, is it serious? Yes and no. Serious if you don't treat it or address it properly in an appropriate time. And no, in case if you diagnose it early, you have a very high chance of cure rate.
Okay. So, sir, is it non-invasive, or they say the bladder cancer is invasive or not invasive? So what exactly is that, sir?
Okay. So before we go into whether it is invasive, because the word itself is very scary. Yes. When somebody says you have an invasive bladder cancer, people get really scared about it when they read the reports. To address this issue, I'll get some basics very sort of correct right at this sort of beginning of the talk. Many of these people with the bladder cancer, men, women, young, sort of elderly, present with bleeding in the urine, which is called as hematuria. And sometimes they get clots because the bleeding stays in the bladder and then form the clots. And who are the people who are at risk of developing bladder cancer? The patients who smoke, patients who eat tobacco. When I worked in England, I thought most of the people who smoke and chew tobacco are responsible for having bladder cancer. But coming back to India, I realized even in villages, the women use tobacco as a mystery to put it to the gums so that they really get sort of kick in the morning and feel better. So even that mystery is also responsible for bladder cancer. The second most common cause is infections. If you have repeated, then you have stones in the bladder which are untreated. And now we know also the genetic makeup of how the bladder cancer is formed. And when patients present with these kind of symptoms, we do a basic sonography. We test urine for some malignant cells done by excellent pathologists. And once we know there is some lesion in the bladder, then we do a CT scan. And subsequently, what we do is something called as cystoscopy, meaning looking through the endoscope and seeing where the growth is, what type of growth is. So whenever you get sort of bleeding in the elderly patients, one thing you should think about is the bladder cancer. Even in the young and middle age, you should think of bladder cancer. And this is how different sort of types of stages of the bladder cancer. Now, this is how when we put a cystoscope, this is into the bladder itself. You can see a growth within the bladder. That is typically called as a bladder cancer. Now, coming to your question, which anybody would like to know, even the pathologist, even the referring doctor, physician.
I want to ask you the grading and the staging of bladder cancer, sir.
Yes. So this is also I'm going to sort of include in your question as such, because I knew you're going to ask the next one. So the bladder cancer is basically divided into two groups, which is called as non-muscle invasive. We don't use the terminology superficial because people feel superficial is not a serious thing. It's not. You have sort of a non-muscle invasive bladder cancer, meaning going into the muscle or not, or there is a muscle invasive bladder cancer. Okay. Now, I'm going to explain here what is invasion. The invasion can be, there are about 5 layers of the bladder. One yellow which is seen is something called as a mucosa. Subsequently, you get a lamina propria. Then you get a superficial muscle and a deep muscle. Now, any tumor which has a potential of going into these layers is called as an invasive one, right? According to degree of invasion, the stage usually starts, and then you know these patients really have a high-grade lesion or a low-grade lesion. To make it simple, just to tell you, 70 to 80% of the bladder cancer, when they present initially, they are non-muscle invasive. So that's a good news. You have either called as a TA or TI or carcinoma in situ, they are at presentation. The worst part is 50% of these non-muscle invasive bladder cancers, they usually recur in 5 years' time. So you need to sort of check these bladders every now and then. Rest 20 to 30% are invasive, going into the muscle of the bladder, and they need a different kind of treatment. But 5-year survivability in these patients is also not bad. It is something in the range of more than 50%. Now you talked about grade. Either it's a low grade or it's a high grade. Previously, we used to have a grade 1 and 2, and that used to confuse the pathologists. So all over the globe, the pathologists have come to a conclusion, either it can be a low grade or a high grade. So stage-wise, it can be carcinoma in situ, meaning only limited to the lining of the bladder here. They're not going into the one of the 5 layers of the bladder.
5 layers of the bladder. Okay.
TA means it is just almost reaching to the submucosa. T1, there is a layer called as a lamina propria, the yellow one. It is called as T1. And when you talk about T2, you can see the muscle is infiltrated. The bladder muscle, the brown one, is a superficial muscle involved, is called as T2. And when you get T3, it is going into both the layers of the bladder, and T4 is almost going beyond the bladder. And T4 plus more than that, it is going into the visceral organs. So this is how the staging of the bladder cancer. So you know about stage and you know about the grade of the bladder cancer. Now you have to have permutation combination. When the patient reads the report, when even the general practitioner or referring doctor reads the report, he would know what stage is, meaning it's just limited to the wall. Lamina propria, going into the muscle as such. So they are first 3 are non-muscle invasive. They go into muscle, they are muscle invasive. And they are categorized into low grade and high grade. Very interesting point. Early stage, small stage or early stage, they usually have something like a low grade or high grade. Right? But if you go further, T2, T4, they are never low grade. They're usually high grade. So when you see the report, if it's a low grade, then just think about it whether it is a non-muscle invasive or not. If it's a high grade, certainly these things are to be, understood. So this is basically a pathology I'm talking about. Yes.
So that means the different treatment options are grade-wise.
Yes. Yes. So that distinction is important because if you know which ones they are, and how do we know? We do an operation which is called as a transurethral resection of the bladder of tumor. So initially we do a sonography, CT scan, and then we take the patients for a procedure called as a cystoscopy, where patient is put to sleep or anesthesia. Yeah. We put an instrument, there is no cut on the body, go inside, and then you see what kind of lesion the bladder has. We, with the lasers, with electrocautery, we resect the tumor completely and send it for the pathologist. And at the end of operation, we resect the base of that tumor to find out whether there is invasion of the muscle or not. Now, this operation is the important operation. I always said whenever I gone across the globe to tell people that this operation is one of the most important operations in urological cancers. If you get this wrong, the patient's outcome, treatment outcome, and the prognosis is also significantly gets changed. Now, if you don't do this operation properly, if you do half-heartedly, you don't know what is the grade and what is the stage. Because if your grade is known, then you can plan the treatment properly. If you know the stage, you can do the properly. But if you do it half-heartedly, you can't. So this is important. First step, do something called as a transurethral resection of the bladder. Now, people feel that when you do this is TURBT, transurethral bladder, is just sort of curative procedure for non-muscle invasive disease. It is not. We resect the tumor and then subsequently give them a treatment. Now, if the patient has no muscle invasion, I'll explain you what treatment we offer. If there is invasion of the muscle, I'll also explain you what kind of treatment is offered.
Sir, post-surgery, do we give any kind of radiotherapy or chemotherapy also?
That's an interesting question, because when patients come for a counseling, I tell them, see, the first important assessment, like, the battle of bladder cancer is won or lost in the first assessment, I tell them. So once that is done, it is not going to be stopped there. If it is a non-muscle invasive, we offer this patient something called as an intravesical therapy. Many times, immediately after doing that bladder cancer operation, TURBT, we put in an installation which is called as a mitomycin C immediately after the operation, within 6 hours. And once the report comes and it confirms there is no muscle invasion, we call them for intravesical BCG treatment. People also use mitomycin. People use BCG also. This is a freshly prepared mitomycin, but in cases of high-grade disease, we use BCG. And what we do, we wait for about 3 to 4 weeks after your first operation, allow the wound to heal from inside, and then call them for a weekly installation of that BCG or mitomycin into the bladder. So this is done in the outpatients department. Patient is brought to the hospital. This is a bladder. You imagine, you empty the bladder. This is a Foley catheter. And we instill a mitomycin in a low-grade disease or intravesical BCG in a high-grade TA and T1 disease. Now, we'll discuss about dosing and everything. What we do is keep this sort of BCG into the bladder for an almost hour or so. Now, patient is lying down flat. Then we ask him to rotate the position for the left lateral side, then the opposite side, and lie on the tummy, because that BCG acts on all the layers of the bladder. So this is how we call as the induction course of BCG. We start once a week for 6 weeks, and thereafter we have a maintenance regime which can go for almost like a year or two, and we space it out cystoscopies, meaning checking the bladder every about 3 months during this course. And that's a treatment for non-muscle invasive high-grade bladder cancer.
So, sir, every patient post would have some apprehensions, like how would I carry out my daily activities, work, exercise? So does that get affected in these patients?
Not at all. Patients, even though undergo sort of a major operation for a muscle invasive bladder cancers, patients can lead an excellent quality of life. Now you see the type 1 which I showed you, the first type, non-muscle invasive. They come for 3 days stay in the hospital initially for an endoscopic operation. Then they come after 4 to 6 weeks for weekly intravesical BCG. They come for an hour and go. They can lead an absolutely normal life. Only thing is, they have to stop smoking. They have to stop using tobacco, alcohol, and keep on regular checkups every 3 months for cystoscopies and imaging. And they can lead an excellent quality of life.
So another question which the patients usually have is, does this surgery affect their sex life?
Not really. If you have non-muscle invasive disease, you're not going to do anything to their sexual organs.
Right.
The erectile dysfunction does not take place. The ejaculation doesn't take place. So absolutely no problem at all.
And any difficulty in urination, sir?
When patients undergo surgery, endoscopic surgery, TURBT, they may get a little bit of burning, dysuria just for a few days after surgery. Patients on this intravesical BCG therapy may experience a little bit of LUTS, what we call as lower urinary tract symptoms, meaning they may get a little bit of frequency, urgency, but they usually die down within 48 hours of installation, and not in a great deal problem at all.
And so what are the chances of post-surgery or radiation or chemotherapy? What are the chances of the recurrence of cancer?
Right. Now, let us talk about here, we're talking about non-muscle invasive disease of the bladder. There is no role of radiotherapy, so people should not think about radiation at this stage and grade of the disease. Even in muscle invasive disease, there is no role of radiotherapy, as a primary treatment, and we'll talk about it later. In terms of this immunotherapy, intravesical, what we call as, people do get some symptoms of, fever, chills, rigors, and BCG-related problems. But that has been now largely sorted out globally. I sit on the panel of International Bladder Cancer Network and so many other organizations for bladder cancer, and I can assure you that these symptoms are very less. They can be managed very well. So let people not get scared about what they read about treatment with BCG. If you use inappropriate doses, if you use it immediately after operation, if there is a disease very, very active and aggressive, these patients are not going to respond to this treatment. So there is a myth that they have side effects with this immunotherapy, but large scale people tolerate it. The next question you asked me, whether they recur. I mentioned to you initially about 50 to 60% of the patients of non-muscle invasive disease recur, but the recurrence is not very aggressive. And that's why every 3 months we have to keep on doing endoscopy and keep on vulgarizing these lesions as and when necessary. About 20 to 30%, they progress to muscle invasive disease in the follow-up. And if required, then we'll discuss what kind of treatment is offered to these kind of patients.
Yeah, just said that, sir, but I wanted to ask you what kind of follow-up tests should be advised to them?
For this type of bladder cancer, for first year, they come every 3 months for a check cystoscopy in general.
Okay.
If the progress is good, then you space out this cystoscopy in a broader way, maybe every 6 months. But they at least come for next 5 years for regular checkup, cystoscopy, urine cytology, and imaging. So for this type of bladder cancer.
That's it, sir, from my side. And okay. I really want to thank you for your valuable time. And,
okay, fine. I think what we left was something just very quickly about the second type.
Really great.
Yeah, the second type, which is we talked about the BCG.
Yes, sir.
So what we have not talked about is the muscle invasive bladder cancer.
Okay.
Now, this muscle invasive bladder cancer, as I mentioned to you, can see the bladder specimen. I have removed the entire specimen of the bladder.
Oh.
You see, this is a very, very large growth. It is not a very small growth. And you can see all the layers of the bladder are infiltrated.
Are involved. Yes,
and
sir.
what they require is something called as a cystectomy, which is called as a radical cystectomy. Now you see, this is a CT scan of a man who has sort of a huge growth in the bladder. I've removed his bladder and a prostate, which is called as cystoprostatectomy. So this muscle invasive disease, when it is go into the muscle but not spread everywhere, we do something called as a radical cystoprostatectomy in a man. So man has a bladder, kidneys, ureter, the bladder has been
bladder and the prostate.
So how do we replace the bladder?
Right.
So you can't replace brain, no. You can't replace heart, maybe yes, no. You can replace liver, but you require the same organ. You require heart to be replaced by heart, liver to be replaced by heart, and liver by liver.
Lung by lung. Yeah.
What we do, we create a bladder from an intestine, which is called as a conduit or a neobladder. So there are two ways of doing it. Bridge the gap with the use of small intestine, or we create that sort of a neobladder and put it into the area where the original bladder is. Now I'll show you what we do for the patients and for everybody's benefit. This is 50 centimeters of a small bowel. We take it, patient's own bowel. We take it into the blood supply, and this segment is converted with staplers and anastomosis into a sphere or a pouch. Now, if you can't bring that down to the urethra, then we give a patient called as a conduit. Means both the ureters are joined to this small piece of segment, and patients get a stoma, which is called as urostomy, and patient gets completely cured, and he can lead a very good quality of life. What he leaves with a bag on the tummy, which is called as urostomy. But if you ask me, if you ask bladder cancer survivor, which I'm working for last 35 years, they would say I would require to have no outlet outside, but something inside us.
Very true.
So what is the alternative? We remove the bladder. This is an operation from within. And what we do is we take a piece of intestine, which is about 50 to 60 centimeter. And how you configure the bladder, and this is I call it as a Studer's neobladder, where this is sort of in a loop of intestine where the ureter gets anastomosed. And you can see this is an artificial bladder created by patient's own intestine, which is called as a neobladder. And this has been replaced inside the patient's tummy. And this is how it looks like. And you see there is no stoma on the patient's body.
Yes, sir.
This functions very well. A lot of people have an apprehension whether it will function or not. And I'll show you, this is an X-ray done after this operation. And for the experts also, they would not be able to make out whether the patient has his own bladder or bladder made of intestine. This surgery I done almost 25 years ago. And you see how patient is doing extremely well. And this is an operation for muscle invasive bladder cancer. I thought the discussion would be incomplete if we don't talk about it.
This would have really been incomplete without seeing the surgery, because it's just an awesome thing to do. So you're routinely doing this?
I think to make it people aware, I'm in this for the last 30 years. We have treated more than 5,000 bladder cancers so far, and we've done more than 500 cystectomies and reconstruction of either conduit or a neobladder in my last 30 years career. I've been going globally around. I've been teaching across the globe. I've been to around 70 countries, talking about this, and also training people how to make neobladders and conduit. So that's my mission. Take the urological oncology across the globe and train as many people as possible and cure these patients with bladder cancer.
So actually, I think we are really lucky to have been seeing this today. I mean, I was not aware of this at all, seriously.
So viewers, if you have any questions or query, please forward it. You can mail me, you can go on my website. I'm more than happy to help you.
We have the email ID right here. I think our viewers will take full advantage of this to get back to you in case of any queries that they have. So at the end of the session, sir, I would really thank you for your valuable time. And in fact, it's been a very, very informative session, very interactive session.
Right.
And I'm very sure the audience must have taken full advantage of it and enjoyed themselves.
Sure. Thank you, Dr. Gulshan.
On this platform, sir, we really value your time.
Yeah. Thank you for the opportunity.
Thank you so much, sir.